Now, let's talk about another process or processes that can occur is when you have cell injuries, intracellular accumulations. So these are molecules that are accumulating. So you have to think of the various cells or tissues that make these molecules, and as they accumulate, what's going to happen to the tissues. For example, lipids. What's the one organ in the body that controls lipid metabolism? Is the liver. So when you have damage to cells that control lipid, like the hepatocytes, what do we think of? We think of the term called fatty change. Because if you damage the liver, like in alcohol, or what virus that can lead to fatty change is hepatitis C. Or you accumulate lipid, for example, in atherosclerotic plaques extracellularly. We call that atherosclerotic plaques, or cells that phagocytize lipid. And what's the one cell that you should always remember when there's destruction to tissue and there's a release of lipid from the plasma membrane and other membrane-bound organelles is going to be macrophages. And so we talked about xanthomas when you have a hyperlipidemic state where there's triglycerides or you think of cholesterol. Then there are things that accumulate. We think of complex lipids like sphingomyelin or sphinglipid. Accumulation, think of the disease of Niemann-Pick, where you can't break it down and it accumulates in the cells and neurons as well as macrophages. And we'll get to that when we talk about the genetic disorders of lysosomal storage diseases. Proteins can also accumulate. And what's a classic example of this? When you have basically a problem called nephrotic syndrome, which is a disease where you have increased vascular permeability to the glomerular capillary membrane and essentially leading to protein. And whereas 80% of your absorption takes place in the nephron is the proximal tubules, and therefore you're going to get what are called hyaline droplets. So what do we use to describe proteinaceous? Because it's pink, is hyaline. So hyaline means the color pink. It's a microscopic description. Russell bodies. What cells make antibodies are plasma cells, and if they make so much antibody and accumulates within the Golgi apparatus, it can lead to what we call Russell bodies. It'll be hyaline. And then what cells control glycogen metabolism? You think of hepatocytes, you think of skeletal muscle and cardiac cells, and so you think of the category of glycogen storage disease where you can't get rid of glucose and accumulates as glycogen, and it's going to make since glycogen has no color, it can lead to pale coloration to the organs that are affected by this. Other things that can accumulate, exogenous pigments, anthracotic pigments. We think of anthracosis, means a condition of accumulating carbon. We think of diseases like, for example, coal workers, pneumoconiosis, where you have inhalation of carbon material. But if you burn organic material, incomplete combustion, you produce carbon. It will now accumulate, and we call that process anthracosis. And what cell loves to eat carbon is macrophages. Tattoos are a common thing that one sees, but you didn't realize, but tattoos explain many, many human diseases. And tattoos, when you get a tattoo, is this basically pigment that you ingest. You basically is being ingested by macrophages in your dermis when you do get a tattoo. And the question is, what happens to a tattoo as a function of time over the years pass and decades? It fades. And knowing why it fades helps you explain many, many human diseases. And how is this so? Remember I told you an important variable in medicine and any disease process reflection of the pathogenesis is the variable of time. And when you ask the question, why does that tattoo going to fade, is the following reason. When you think of what cell that you've memorized the lifespan of is a red blood cell. You can recite it no matter what medical school and the university you come from or country. You always tell that in human beings the average lifespan is 120 days. But when have you used that number? At a cocktail party to impress people that you've gone to medical school? No. But there's another cell that's very critical that lives also 60 to 120 days is a macrophage. So when you get a tattoo and you think of the process of ingestion of that pigment, what that macrophage is doing is when it gobbles it up, it migrates. It's not just a stationary cell. Remember, our cells are in a dynamic process, and it dies every 60 to 120 days. Another set of macrophages come in and ingest that pigment. As a function of time, what's going to happen to that tattoo? It's going to basically not look as sharp, out of focus. It'll become more out of focus as a function of time. Why is that important? Because what cell in any disease process that's going to be there for days, weeks, months, or years, or decades, that lives 60 to 120 days, is a macrophage. And that macrophage, as you're going to see, is what you as clinicians or medical students have to deal with. And so when's the best time in life to get a tattoo, you might ask? Is before you die. You won't have time to go through this process. So ingestion of lead or deposition, lead line, and when you have lead poisoning or renal tubular lead deposition. So when we think of what's the most common chronic heavy metal poisoning in the United States, is lead poison. And so what is every child before they enter elementary school has to get a lead level by the pediatrician, because it can lead to acquired mental retardation or slow learners. Endogenous pigments, we think of lipofuscin. Lipofuscin is a wear and tear pigment. You think of, as I mentioned earlier, involving highly metabolic organs like the heart, myocardial cells, as well as hepatocytes, and you usually see that above the age of 40, so the older you get, the more lipofuscin deposition. It's a yellow-brown pigment, and you can also, where's a common place you can find it? If you forget what color it is, a golden brown pigment that you can see on physical exam is earwax. That's why earwax is golden brown, because the ceruloplasmin glands in the external meatus makes a lot of lipofuscin. That's why earwax is yellow-brown. So in the middle of the exam, when you're taking USMLE, just pop your finger in your ear, pull it out, and you know what lipofuscin looks like. Melanin, what amino acid gives rise to melanin is tyrosine. And obviously, if you don't make enough, if you have an inborn error of metabolism like albinism, where you can't take tyrosine and convert it to melanin, what are you going to develop? Albinism. So you have to worry about what? You have to worry about skin cancer. And so the skin cancer you think of is basal cell and squamous cell carcinoma. Where else do you make melanin in the body besides melanocytes? Is substantia nigra. What disease destroys the neurons in substantia nigra, as you recall, is Parkinson's. And so that's a reflection. Now, what's another place you make melanin? Is in your retina. Remember, you have the pigmented layer in the retina. And can you get intraocular melanomas? Yes, from those melanin-containing cells. Hemosiderin, an important protein that's bound to iron. So it's iron bound to a protein. We call this hemosiderin. And hemosiderin is a breakdown of red blood cell. And what cell plays an important role in breaking down red blood cells in any disease process where you have bleeding is the macrophage. And it's going to be a yellow-brown granular pigment. And you think of macrophages, but cells, when you think of disease like hemosiderosis and hemochromatosis, it can be accumulated in bile duct cells, hepatocytes, myocardial cells, endocrine cells as well. And obviously the most common cause of hemosiderosis is simply getting extravasation of red blood cells, like in a bruise or a hematoma, hemorrhage. And then, as I talked about before, increased total body iron stores without tissue damage. What do we call that? Hemosiderosis. With tissue damage, hemochromatosis. An old clinical term for it is bronze diabetes. Remember, when you have primary hemochromatosis, we have increased absorption of iron from your diet. And what's the stain that we use to find this in tissue is Prussian blue. And then another pigment that you can make is bilirubin. It's a yellow pigment. And you see this in terms you have to worry about kernicterus because of the immature blood-brain barrier. But once you get beyond several months after birth, in a normal gestational age, then you have the ability to prevent bilirubin from crossing the blood-brain barrier. So when you're an adult or an adolescent and you turn bright yellow because of some type of problem with bilirubin, your brain will still remain white, especially the white matter. Hyaline change, we mentioned, when you hear this as a microscopic term, it means there's protein. And so you think of things like hyaline cartilage, where you think it's pink because it has a lot of protein. So protein can be intracellular or extracellular, depending upon what the protein is accumulating. For example, the intracellular hyaline, you think of those reabsorption droplets that you see because of protein, because of nephrotic syndrome. Remember, what's the difference between a disease and a syndrome? Disease has a unique etiology, it has unique symptoms and signs, while a syndrome has what? Multiple etiologies, but a unique clinical presentation. So on the USMLE, they'll often give you the definition of disease, not tell you what the disease is, just based on the symptoms and signs. So there's multiple etiologies. You think of it as a syndrome. And there's a lot of syndromes you learned about that one sees. Russell bodies, we talked about that. Intracellular, you think of that in terms of too much antibody response or production in response to some type of antigenic stimulation, like an infection, for example. Alcoholic hyaline or Mallory bodies is another name for this, where you have the injury to the cytoskeletal protein, intermediate filament. We talked about this earlier, cytokeratin. And it's reversible. It usually lasts about 8 weeks, and then we'll go back to a normal state once it's degraded and not clumped. What are examples of extracellular hyaline? Is hyaline arteriosclerosis. These are things that will produce this as aging, hypertension, diabetes mellitus. We increase the structural proteins in the wall becomes thicker, decreased lumen, decreased perfusion, lead to ischemic damage. And you can see this with hypertension, as I pointed out, is a common, especially benign hypertension. What's the definition of amyloidosis? Condition of abnormal or pathologic deposition of extracellular protein leading to organ dysfunction. And it can be in blood vessels or in the interstitium of the tissue that's being affected. And then you have a hyaline, again microscopic. You think of hyaline membranes, it's pink, and you think of it in ARDS, acute respiratory distress syndrome, or in prematurity, where you have the newborn is premature. And remember, what's the one organ system that's developing the last part prior to birth is the respiratory tract system. There's not enough surfactant being made, and so once they get exposed to the oxygen in the environment, they can lead to acute alveolar damage or acute lung injury, and we call that hyaline membrane disease of newborns. So it's prematurity that's associated with this. Versus ARDS, or acute respiratory distress syndrome, you have some type of disease process that injures the alveolar sacs, either from the inhalation of some toxin, vapor, or dust, or you could have it from the intravascular side, antibodies, immunocomplexes, shock, endotoxin, you name it. The last thing we want to talk about in this chapter is calcifications. And there are two forms of calcifications that become important to understand. There's what is called dystrophic calcification, where basically what happens is you get calcium precipitation, especially with phosphate. And this can be in degenerating or dying tissue or tissue that's becoming necrotic. And it can be a normal process as degeneration. As you age, obviously, tissues start to degenerate. They can become calcified as a function of time. And it can be important in detecting, obviously, in radiographs or CT scans when you have abnormal calcifications versus degenerative changes in tissue you normally suspect or anticipate because of age-related changes. So what are some examples to illustrate this? Well, obviously, when you have fat necrosis, whether trauma, like to the female breast, or you have fat trauma to the pelvis, where you have a lot of fat deposition, or in pancreatitis, you can release the free fatty acids from the adipocytes that can now bind to calcium. We call this process, remember, saponification. It'll look purple or blue in the surrounding area. What's another example of dystrophic calcification? Now, they get different names, but it means the same thing. Is there degeneration of tissue? Somoma bodies. Remember, these are concentric laminations of calcium in degenerating tumors. And the other things you think of that have papillary structures, you think of papillary carcinoma of the thyroid, papillary tumors, benign and malignant of the ovary. And you can also see it in meningiomas as well as malignant mesotheliomas. So this is a reflection of degeneration of tumor, because remember, calcifications can be as picked up on radiographs. Muckebergs, or medial calcific sclerosis of muscular arteries. There's a degenerative process. This can also be seen in conjunction with atherosclerosis, because atherosclerosis is a dystrophic calcification of the intima. Remember, Muckebergs is of the media. Now, because Muckebergs affects the media and does not affect the lumen, like the intimal disease atherosclerosis, you're not going to see clinically any changes to problems with oxygen delivery. But you will if you decrease the lumen with a disease that affects the intima, like atherosclerosis, then you're going to lead to hypoxic damage. And then, as I mentioned earlier, atherosclerotic plaques, as they become more complex over decades, it takes time for this process, it can lead to calcification. So you remember when you took gross anatomy class and you had all those older cadavers, and when you got to the dissection of the aorta, you noticed those aortas were kind of crunchy in terms of hard because of the atherosclerotic process in terms of degeneration that took decades to take place. Another form of calcification that's important to remember is metastatic. And when you talk about metastatic, what's another name for metastatic? Widespread. And so when you talk about metastatic calcification, what does that patient have to have in the clinical scenario is hypercalcemia. And hypercalcemia, remember the normal calcium level in your blood is 8.5 to 10.5 milligrams per deciliter. So anything above 10.5 is going to lead to hypercalcemia and the potential for calcium. Remember, it's a divalent cation. It's positive. It's going to look for negative charges to bind to and lead to calcium salt formation. So what are causes? The obvious thing, as I told you, what's important in the USMLE that I like to ask about is calcium metabolism. So there are going to be hormones and vitamins that are going to affect calcium metabolism. So hyperparathyroidism, where remember the parathyroid hormone, which is 84 amino acids in length, a polypeptide, has two effects on calcium. It will release, through the action of the osteoblasts, the release of calcium. Remember, 99% of your calcium is stored in bone. And what is it? Parathyroid hormone has another effect on what organ? Is the kidney. It affects the tubular reabsorption of calcium to increase calcium levels. So what's a common cause of hyperparathyroidism is a parathyroid adenoma. Remember, what's the most common tumor of any endocrine organ is not carcinoma, but adenomas. And you'll rarely see carcinomas in the endocrine system. So if you know adenoma for all endocrine organs, you know them all. On exams, they tend to be functional. In real life, they tend to be non-functional. Renal failure. Obviously, renal failure is going to lead to what? Why would that lead to metastatic calcification? Let's think about it. The kidney has many functions, but one of the things it can't do is can't hydroxylate vitamin D. So if you don't have enough vitamin D, you're not going to have the ability to reabsorb calcium. So where are you going to release calcium? From your bone. And that can lead to what we call secondary hyperparathyroidism in response to this. Then paraneoplastic syndrome. There are parathyroid-like hormone that can be produced. What are classic examples that produce this that you think of is small cell carcinoma of the lung? That it's a neuroendocrine cell that can lead to increased calcium. Another one that can do it in the lung is squamous cell carcinoma. It can also lead to hypercalcemia. Vitamin D intoxication. If you have people with peptic ulcer disease, one of the things they drink gallons of milk and they have too much fortified vitamin D, it can lead to increased absorption of too much calcium in your diet, leading to hypercalcemia. So you have to drink just enough milk, but not too much. And then metastatic calcification, other causes you have to think of, as I mentioned, milk alkali syndrome, because you're drinking all that milk, because the milk is acting as a buffer to the acid produced in the stomach, and so, but you're going to be releasing a lot of acid, so you're going to get a metabolic alkalosis in response to this, and leading to metastatic calcification. Sarcoidosis. Well, how is this going to be leading to hypercalcemia? And again, this is a reflection of these macrophages that make up these granulomas, is that they will increase hydroxylation of vitamin D. So if you have more hydroxylated vitamin D, more active form, now you're going to increase the absorption of calcium in your diet and lead to hypercalcemia. Paget's disease, which is Paget's disease of the bone, where you have increased osteoclastic activity. They can release calcium and lead to hypercalcemia. Multiple myeloma, a malignancy of plasma cells, destroying bone. Leukemias destroy bone, releases calcium. What's the most common cancer found in bone is metastasis, breast, renal, GI, melanoma. Most cancers that go to bone are osteolytic. What's the one cancer that tends to be osteoblastic? Is prostate cancer. And so here we have the deposition of calcium going into the interstitial tissues, but it also cross through blood vessels. But when you look at this list, we have the stomach, the kidneys, the lungs, the blood vessels. Now, what do we know about lists that we started out in the beginning is that once you do a list or underline it right now in your notes, you're going to forget it, right? So what do we look for in any list is a common denominator. And you can add, once you figure out the common denominator in this list, you can add other organs to it. If you look at this list, what do they have all in common? They have a large blood volume. So where's calcium going to go? Into those that are highly vascularized tissues. So what other organs could you add that could get metastatic calcification in the blood vessels, the interstitium? Is your skin, your brain, the very thing you're trying to figure out right now. You can think of it in your other organs that have a lot of blood vessels, the liver, for example, spleen. So it's going to go to those tissues that have a lot of blood flow or large capillary beds.